CPCQC. Thank you, Sydney. We will dive right in. So today we are going to be talking about race, ethnicity, and language data to really focus on health equity. And then we'll be talking about some 2024 updates, trainings, and what to expect. But really quickly, we would like to release a poll to see which hospitals have used or are actively using the Support Colorado indications for tox testing. We'd really like to share this data back with them. Give that just a couple minutes. It's not to get anyone in any trouble for not using it. We just want to make sure that people are using it and that we are promoting appropriately.
If you're not using it and you have any insight onto why that is or barriers that you've had to using it, we'd love to hear that either in the chat or feel free to send us an email. We can be partners in figuring out ways to support you.
I'll give it about 30 more seconds so you can respond. Okay, thank you all for that insight. If you would like to respond later in an email with any feedback, please do so. We would be happy to review that as well. I will now pass it over to Amber.
Thank you. So we have a guest speaker today. I am super thrilled to see so many people on the call today, because if I could make every single perinatal provider attend this talk, I would, but we will start where we can. So today we have Dr. Corey Hussain, who is a board certified internal medicine and infectious diseases and preventive medicine physician. He's also an associate chief medical information officer at Denver Health, and he is an assistant professor of medicine at the University of Colorado School of Medicine. Corey and his team at Denver Health have done some really amazing work on inclusive race and ethnicity data collection. And you guys know, as part of our perinatal substance use programming and our quality improvement, we collect data on race, ethnicity, and payer in order to identify disparities in care practices and outcomes. And sometimes we get a little feedback on, well, it's challenging to collect that data, or there's not really great data available. And I think Corey is an excellent example about why putting the time and effort into race and ethnicity data collection is so important, and maybe giving some insight into why it's so hard in order for us to be able to do that. So Corey, I will hand it over to you. Thank you.
Sorry if I sound a little hoarse. I'm still drinking my tea with my sore throat. So thanks everyone for coming to this meeting. I understand, before I even start, that collecting race, ethnicity, and language data can be a little challenging with, it's a very touchy subject for a lot of our both frontline staff as well as our patients as well. Generally we have responses where we started collecting. We actually did a lot of observations just standing there at the front desk when the registration staff is going through these questions. And I think the number one thing that I heard was, why are you asking me this question, right? Like, why do you need to know what my race and ethnicity is? So let me share with you our journey on this. And hopefully this is the, the way we decided to do our race and ethnicity data collection. Does not mean that that is the best way to do it. It's just one possible way, but it's a good framework for everyone on this call to understand where your data is, what percentage of your data is missing, Nationwide, the average tends to be anywhere between 11 to 15% of your individuals do lack both either race or ethnicity data. And then also understand what processes you have in your own institution, which could make this data collection better. So let me see if I can share this correctly. My screen is huge, so if this looks really odd on your screens, please let me know. Can you see my presentation? Since I have it up, is it there for everyone? Okay, perfect. So this is, we named it race, ethnicity, and language. How we ask questions matters, right? Because if you don't ask them correctly, you're not going to get the answers correct as well. So I don't have any financial relationships with any ineligible companies to disclose. So Denver Health is, we presented this at the users group meeting about 2 years ago at Epic. These slides are from that. It's a pretty large safety net academic level 1 trauma center. As you understand, it's got 11 primary care clinics, 19 school-based clinics. We have 1,350 physicians, 2,000 learners, and 215,000 patients, with 900,000 outpatient visits and 23,000 inpatient visits. We also have the Rocky Mountain Poison and Drug Safety, paramedics, public health, school-based health centers, blah, 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 a lot of things. So our learning objective should be why race and ethnicity data collection is important for health equity, identify processes of making sure registration asks these questions in a patient-friendly way, and outlining the importance of prioritizing this data collection for each of your own organizations. This would have not been possible with a lot of people who worked with this, including our former CEO, as well as multiple people in multiple divisions all throughout the organization. So, fundamental race, ethnicity, and language is fundamental to the foundation of trying to reduce disparities. We know that disparities in quality of care are a huge challenge. We need to address these. And they understand that the importance of systematic, standardized data collection is foundational to advancing health equity. And let me explain to you why. So one, in order to detect differences in healthcare groups, you first need to know who they are. You need to define the healthcare disparities. You need to define and identify the vulnerable populations, and then you need to be able to measure those disparities, right? Then after you do that, at patient level, at a clinical encounter level, you can try to understand what those determinants of disparities are. Is it their social vulnerability index? Are they very poor? And intersectionality starts playing a role in that as well, right? You have, women who are Black and live within areas that are relatively underprivileged or resourced will have worse health outcomes, and we know that, right, from all the literature out there and the studies that have been done. But within your own population, who are the other groups of individuals or cohorts that could be experiencing disparities, especially with perinatal care, which is what your group is really interested in. And then designing interventions, right? Because you want to design the interventions that address those disparities, knowing that this group who is at higher risk for, let's say, postpartum hemorrhage or low birth weight, what are some of the things that you can do within those groups in terms of education and a community outreach to try to improve those outcomes at a population level. And then once you put those interventions in and you measure them, then you can create policy around it. Well, the problem starts right at the base, right? Most of us sometimes don't know who these people are, and try to measure who these individuals are by trying to figure out what their race or ethnicity is or what languages they speak. When it comes to race and ethnicity, there was a standardization for healthcare quality improvement published by the Institute of Medicine in 2011. They actually standardized how you would ask these questions, how you would approach this. And this is one of those documents that was so well done and pretty much went nowhere in terms of improving race, ethnicity, and language collection practices, primarily because there was never the impetus associated with, health equity work until about both George Floyd and then the pandemic happening, and then seeing significant disparity, especially with COVID outcomes. As you all know, these are some of the categories that OMB asks us to collect, including the ethnicity and the race. So when we don't know, in terms of patterns, everything kind of looks like that, white, fuzzy, non-discriminatory. We can't see anything. Once we do know, then the data becomes enriched and we're starting to see some patterns and we can see where interventions might need to happen. So our journey started with understanding what is going on, right? So we actually went and worked with the front desk registration staff, and 4 things really stood out. So this was our root cause analysis. The front desk and the patients themselves did not know even what the definitions of race and ethnicity are. And you might be surprised at your own organization by going up to your registration staff and asking them, could you define what race and ethnicity is? And you might actually get 45 different responses on what they actually mean. It could be pretty differing. Also, there was no standardized way of how these questions were asked. So people would go like, were you born in the United States? Or do you speak English? And we're like, those are leading questions. You can't do that. And then the third one, which was really important, is patients themselves did not, especially in our immigrant population, did not identify with those broad categories of race and ethnicity. Repeatedly, we heard, well, I'm Hispanic or I'm Latino. Why are you asking me my race? Because for the Hispanic Latino community, that is their race, right? They don't identify as white, black, or any of the other categories. For our NENS patients, non-English, non-Spanish speakers, we have a pretty large immigrant community, and I'll share that data with you. They would be like, well, I am Sudanese or I am Vietnamese. I don't understand white or black. So we started asking individuals, when we asked them what their race were, they would give us their ethnic background. I'm Cameroonian, I am Ethiopian, I'm Eritrean. They would not identify with their race at all. Some people did. People who were born in the United States, they are used to these questions, right? We are used to going in and filling out forms that say Black, white, Pacific Islander, etc. But for a lot of individuals who come here, especially as immigrants who face a lot of disparities because of not being able to speak the language, they do not identify with the OMB race categories. So this is some of the things that we came up with, which I just went through. So we decided that we want to go with some best practices, right? Communication from leadership. So we want this as a systemic, kind of like an initiative from the top down, like we need to do something about that. We need to have robust staff training. We have to have alignment across our institution. The most important thing was to have adequate materials, right? Especially scripting. We wanted to make sure we created a document and then also really give patients the autonomy to self-identify themselves, whoever they are. So when people talk to me and go like, well, how did you validate your data? I'm like, you can't. You can't validate someone's self-identification. If someone tells you, I was born in Vietnam, I'm Black, and I speak Korean, you've got to take that for face value. You cannot question that. So this was our fields of how we used to ask. We created this new field of ethnic background. And why we did that is what we understood that most people actually identify with some kind of a background. And then the ethnic background would then map to a race or ethnicity category, depending on what their ethnic background was. So for example, if someone said, I'm Somalian, it would automatically map to Hispanic, Latin, not Hispanic or Latino. And the patient race, we would map it to Black or African. However, when we mapped these, we still asked them. We would be like, oh, you identified as Somalian, it's mapping to Black or African, and it's mapping to not Hispanic or Latino. And what we found out was the concordance of the mapping depended on what your ethnic background was. And I'm happy to share the document for the ethnic background with the whole group, how the mapping was done. What we found out was it worked for a lot of our, like, for example, if someone came in and said, I'm white, it would map to patient race, white or Caucasian, and the Hispanic Latino would be left blank because we did not know, because a lot of white individuals who identify as white might also be Hispanic or Latino. So we would ask them that question. For our non-English, non-Spanish speaking patients, when we asked them if you're Hispanic or Latino, it created huge amounts of confusion. So if you ask somebody from Ethiopia, Eritrea, Vietnam, if you're Hispanic or Latino, they were just like, what? So we decided to map non-Hispanic, non-Latino ethnic background. So, if you're not Venezuelan or Nicaraguan or Honduran and all of those, we decided not to ask you that question. Now, for certain things, we left it blank. So if you're Black, white, American, those kind of things where you recognize yourself as a certain race as your ethnic background, we left the Hispanic and Latino, including Brazilian, because you could still identify yourself as Latino, not necessarily Hispanic. And those questions were asked. But if you're from like African countries or from India, for example, right, we automatically just mapped it to not Hispanic, Latino, and just left it at that. So this is kind of like the script. We standardized the script, and how we did that is we asked different iterations of those questions and then calculated which question type had the best response rate, not accuracy, because you cannot accurately ask someone what your race is, right, or what the ethnic background is. This is autonomy of self. This is the autonomy. This is the self autonomy question. Sorry for that. There was a phone call coming in. Of how they reported themselves. So the question was like, I'm going to ask some questions about your background. We ask these questions so we can provide the best care to our patients. And this was, what ethnic background do you identify with? And a lot of the times we had to like say, where's your family from? And most people understood that. And so I'll show you how our data looked like after that. And for Hispanic, Chicano, and we've changed Latinx to Latino because this is an older script, because most of our patients actually responded that Latinx was not a term that was commonly used within the Latino community. So, and most women within the Latino community were okay with, having the word, are you Hispanic, Chicano, or Latino? One of the things that we really did was the Spanish script was not a translation, but a transcreation. What transcreation is actually asking the question how a native Spanish speaker within South and Central America would actually ask that question from other individuals. So don't translate, transcreate, especially. We were not able to transcreate this, of course, in other languages, though we would love to at some point. But how we do for other languages is we ask the question in English, and then we have a translator who asks the question in the native tongue. And generally, that's the process of transcreation because they know how those questions need to be asked. This is kind of like our advertising campaign. All of the credit goes to Robert Wood Johnson Foundation. They did this work in 2012. So all of this stuff has been around for more than a decade. It's just so interesting to me that now we're all of a sudden just grasping onto this because we've realized our data is so bad. And this really represented, all of these are all our patients. These are people that come to Denver Health. We asked all of these individuals if we could take pictures of them. This is our diverse community. And all the people that are over there, like Manuel Pinado, he is a patient care navigator, phenomenal individual, really helped us in building some of our scripts and was instrumental in working with us. I cannot thank the frontline registration staff to be completely engaged with us. We also had some patient representatives who were very engaged in giving us, their opinions on how these questions could be asked better. What we are doing in part of our phase 2 is actually going back and going to be surveying our patients who are registering at Denver Health for the next year. We're submitting a grant to see how they feel about answering these questions, because now we want to see what the patient-reported outcomes are to our own methodology. So how are we doing? This is a pre and post implementation. So we have ethnic background. Here are our top 15 ethnic backgrounds that we've collected. So far in Denver Health, we now have 391 different ethnic backgrounds in our patients, ranging from majority of the patients recognizing themselves from 96% as one ethnic background, about 2.1% recognizing themselves as 2 or more ethnic backgrounds, and one patient with 23 ethnic backgrounds, which, you always have to have that outlier, right? We do not have any limit on how many ethnic backgrounds we can select. So this is what happened with our patient racial identity pre and post real implementation. If you can see my mouse, you see that our pre and post white went from 66 to 63.6%. What was really interesting is our other ethnicity, which is not having to select any of the OMB races, went from 8.9 to 14.1%. Within this, 50% of our individuals identified themselves as an ethnic background of Hispanic, which really goes to show that Hispanic and Latino and Chicano individuals do not recognize themselves as any other race. They recognize themselves as a Hispanic, Latino, Chicano race. And fortunately, OMB has heard that. And coming sometime this year, the OMB categories, ethnicity is going to go away. Hispanic, Chicano, Latino is going to become its own race. Our Black and African American population was now being recognized a lot more accurately. But what was really interesting is our missing data went from 7 to 1%, and currently it stands at 0.6%. And the reason this happened was because instead of asking people if you're Black, white, we just asked, what do you identify as? And then using that identity to actually map you to a race in order to report, right? We have to report this to the federal systems, the federal authorities, whoever. Our Hispanic category went from 31.2 to 46.6%, which is, you're recognizing that. And our ethnicity went from 8.6% missing down to 1.1% missing. This data is up to 2022. When we looked at the data up to 2023, we're down to 0.6%. Oh, sorry, did anyone have any questions? Sorry, I should. No, okay. We have currently in our system a total of 291 languages. Our languages went from 12.7 missing unknown to 4%. We're currently standing at 1.6%. Again, this data is up to 2022. You also were able to see changes in primary language over time. We had a significant influx after the fall of Afghanistan to the Taliban, a really large proportion of individuals who suddenly came to Denver Health speaking Dari and Pashto. So we were able to track that as well. And this is important because we needed to make sure that we were able to outreach these individuals and have language services for them to know in order to actually navigate our system. Country of birth, we went from 27.4% missing down to 9.6%, and we're currently standing at 5%. Are we improving data on existing patients? So these were patients that we wanted to see, we wanted to match a cohort, right? The cohort that we came to Denver Health before, and the same cohort coming to Denver Health after intervention. So this was about 207,000 patients. And even in that, our unknown went from 2.5 down to 0% and 5.6 down to 1.1%, and this is by ethnicity. Our unknown race went from 2.4 to 0.4, 5.5 to 1%. So this tells you that individuals who were coming to Denver Health before and had an encounter in the year prior to our intervention, and the same individuals, when we looked at their data after the intervention, there was a significant change in the missingness of the data. So what to do with this real data? So we can stratify data and quality of care measures to identify and then eliminate disparities. And I'll share one little project that we did with this. We can track these disparities data over time, right? So we actually saw that we had a sudden increase in the number of people who were having encounters speaking Dari or Pashto. So we wanted to make sure that our Afghani women, especially who are coming into the hospital, are not experiencing significantly disproportionate outcomes, for example, low birth weights, as well as postpartum hemorrhage. And then using this real data to identify potential staffing needs. In our case, it usually tends to be language services or patient navigators. So not everyone is created equal, right? So I wanted to see this breast cancer percentage screening for patients who are Hispanic. And, you know, everyone talks about our Hispanic and Latino community, but everyone talks about it as one amorphous community, like as a whole, like all Hispanic and Latinos, how are we doing with that? So, you know, that's 70.99%. And this was the data 1 year after we had started collecting our race, ethnicity, and language and ethnic backgrounds. But when you split it up by ethnic background, you suddenly started noticing that individuals were Cuban or identified themselves as Chicano Mexican Americans and especially Puerto Ricans were not really meeting those criteria. What was really interesting was Mexicano or Peruvian or Salvadoran, are people who identified themselves as Honduran. They were doing really great. So I wanted to stratify this data further, and then I did the social vulnerability index, and you understand that higher the number, the more the poorer you are, or the more under-resourced you are. And so we started looking at overall SPI percentiles, and we saw that our Cubans and Colombians were by far the most affluent versus our Mexican or Mexicano or Salvadoran. These are individuals who are relatively under-resourced. And then what I did was I wanted to perform the percentage screen versus average overall SPI percentile. And you can see that in our Colombian, the SPI percentile is really low, which means they're relatively affluent, but their percentage screen is really high, which would make sense, right? If you have more resources, you're more likely to get breast cancer screening. What really was interesting about the story was when you started looking at Cubans, and we found that even though they're relatively affluent because they have a low SPI, they also have very low percentage being screened. And again, Hondurans generally tend to be more poorer, but high percentage screening. But the other thing that we also started noticing is individuals like who are Honduran, even though they're poor and high percentage screening, people who identified themselves as Mexican relatively were more poorer, but also had very high percentage screening. And one of the things we found out, which came to light, was we really were targeting our poorer Hispanic patients by doing community outreach, especially individuals who did not speak any English. Within our Spanish-speaking cohort, from countries who are non-affluent, from countries that are impoverished, who are coming in as recent immigrants, we were doing an amazing job because we thought that these patients were not being serviced, right? So we put all our resources in that. For our population in the Cuban community, majority of them spoke English and they weren't very poor. So we kind of like let them go and found out that they had the worst breast cancer screening rates in that community. And we're like, okay, we actually did the opposite, right? We went after a certain sector of the population and did such a great job with it because we thought that they would be under-resourced and underprivileged. And so we did great outreach to them. And then we completely ignored this other group. So I wanted to, before I finish this, I wanted to kind of give you a gist of what we're also doing with the data, right? And how we're collecting other sources of data as well. And I'm happy to pause. I think it's been about 30 minutes. I'm happy to pause before I show you two more dashboards if anyone has any questions, or if you want me to just continue. Yep, no one's saying anything. So you can see, is everyone able to see the Tableau dashboard that I'm sharing? So this is our clinical equity dashboard with reference group comparisons, and our reference group in language, of course, would be English. In race and ethnicity, it would be white, right? And so we decided to actually build these dashboards to look at a 30-day readmission rate, mortality, length of stay, as well as our obstetrics and postpartum care, looking at postpartum hemorrhage, our C-section rates, as well as treating severe hypertension by looking at our race-based how we're doing. And then we can also, for example, postpartum hemorrhage, be able to track this over time. And we can see that we definitely have some work to do in some of our populations, which is interestingly, the postpartum hemorrhage within our white population is higher compared to other populations, right? But overall, we can see that the other, which is individuals who do not recognize themselves as any race, might be at a relatively, are definitely we're performing the best in them and not in other groups as well. The other thing that we've also done during this time, I don't know if your organizations are doing that, is collecting health-related social needs, and that has been a huge push in our organization. We are looking at food insecurity, transportation, housing insecurity. So far, we've screened 88,000 patients. We started this program about 7 months ago inpatient. We're at 92% screening rates. We screen all our individuals in this group by individuals that are requiring interventions. So we're talking about people who are higher tiered. with multiple medical problems, well child visits, as well as individuals who are using our resources in our system at a higher rate, right? People who are coming to the emergency room or have been repeatedly readmitted to the hospital as well. So this is like our new initiative to do social determinants of health. We are combining social determinants of health, race, ethnicity, and language, and then our SOGI data, as well as homelessness status, to really understand our population. So if you look at our clinical equity dashboard, we're actually able to see all of these metrics now with undomiciled status as well. And we've built an undomiciled registry to look at our most disparate patients. And as you can see, our homeless population has a 17.5% readmission rate to the hospital versus 8.2%. So these are some of the other, factors that we're now studying, having improved our race, ethnicity, and language, going now to further defining what are the most vulnerable populations and trying to figure out how we can do a better job in really stratifying our data and really going after communities at risk. And that's all I had.
Corey, that was amazing. I'll kick us off with a question, and I'm hoping that other people also have some questions. This was a big project that you guys undertook, and it took a lot of resources, and it sounds like there was also funding associated with it. For hospitals who want to sort of, or programs who want to sort of like wade into the shallow waters of improvement around race, ethnicity, and language collection, do you have a recommendation for where they might start? Or if they could only do one thing to get started, like what would that one thing be?
I think the first thing, if you really want to do, is I would collapse that into two. One, find out what your data is, where you're at, because unless you already know where you're standing, you don't know what to improve. And with that, find out how the process of collecting that information is in your own organization. I am not advocating for you doing this really large project to really understand the nitty-gritty granular ethnic background, but just to improve the standardized process of how you're asking these questions. You might be surprised just doing a little bit of a dive over there, just standing at your registration desk and seeing the variation and how these things are being asked, and even asking some simple questions like, can you define how you ask these questions? What do you understand by race and ethnicity? Can at least lead you to develop your own standard script, from the input, both from the community that you're serving, as well as the people who are asking these questions, because they are your best resource and advocates for this.
I have a question. I'm wondering, it was impressive to see your last graph on all the data that you have gathered. And I understand you have some additional funding, but I'm wondering how that adding more questions added to the workflow in registration, and how did you convince your team to ask more questions and to get to the results where you are?
So that's a great question. So technically, we only added one question, right? We already had race and ethnicity. So we used to ask race, we used to ask ethnicity, we used to ask birth, country, and your preferred language. So that have always existed. What we added was an ethnic background. And because we added an ethnic background, we took away the cognitive load of trying to make the patient, the registration staff then ask what your race and ethnicity is, right? Because we auto-mapped that already. All they had to do was verify it. So that was one less of an incriminating question, as you can put it. Because the one that we found that was most triggering was, what race are you? And what we found is once we auto-mapped you to a race, and let me show you this because it's actually easier if I show you what the mapping is, so it kind of makes sense. Because everyone's like, what mapping are you talking about? So I'm assuming you can all see the Excel spreadsheet. So if you were, for example, for white, if you were like Prussian, Irish, Italian, Sicilian, Herzegovinian, it all mapped to race white. If you were Polynesian, Samoan, Tahitian, Tongan, it all mapped to Pacific Islander. If you were Black, African American, African, Djibouti, Liberian, Nigerian, Syrian, all of these map to Black or African American. So this is what I mean by our mapping, and really recognizing yourself at that granular ethnic background. Once the mapping occurred, all you had to do was verify it, and we found that that was a lot less, what's the word I'm looking for? A lot less jarring for the patient than what race are you, versus saying you recognize yourself as Djiboutian and it's mapping to African or African American or African or Black. Do you agree with this? Would you like me to change it? And if the patient said, I would like you to change that, we would. We noticed that the change rate was less than 3%. So it's very, our threshold was 5%. If 5% or more changing their race, we need to figure out what's happening. So that was the only question we added. And because we added that question and we improved that process, it led to the improvement of the process for every other question. Because before they were asking you where your birth country is, but they would ask you in ways like, where were you born? Which country were you born in? Were you born in the United States? Are you from here? We wanted to remove all of that and have it being asked only in one way. What is your country of birth, or which country were you born in? The same for ethnicity. We wanted to make sure that if we explain to them, and also we weren't asking ethnicity question to individuals we knew were not Latino or Spanish, because we asked them their language, right? So if you're speaking Armenian or you spoke Azerbaijanian, or Swahili, the question about asking you, are you Hispanic or Latino, kind of goes out the window, because the Hispanic diaspora speaks Spanish, right? So then we just concentrated on what their ethnic background and their race was and what language they spoke, right? But people who we did not map those were people that we weren't sure about. So if you're Black or African American, or if you're white or you're American, which we did get some of those, we would leave the race and the ethnic background blank. And those questions would need to be asked at that point. You identify yourself as American, but what are you Black? Are you white American? Are you Black American? They would give you that answer. Are you Hispanic or Latino? What we noticed was, because we standardized the script, it really took away the guesswork of how to ask those questions for registration staff. They really appreciated that now it was so standard, it was almost like reading something off a piece of paper. And then the other thing we also did, which I didn't tell you about, is we trained our entire staff on how to actually respond to patient concerns or any patient complaints around that. Why are you asking me these questions? What are you going to do with this information? What do you mean who I am? And we created a training module that all our registration staff goes through in order to go through those scenarios and how to respond to them. And that has been one thing this training has been invaluable to our registration staff. They love the fact that not only did we train them on how to ask these questions, we also trained them on how to respond to any difficult patients or difficult questions for the patient.
Corey, our chat is lighting up. I'll let you catch up here. Katie and I are just asking questions of our own questions over here in the chat. Katie asked, from a technical perspective, how were the open-ended answers mapped? And so I think you covered that. And I think the follow-up question to that, Katie and I have is the same question in different versions, is that mapping standardized? Is that unique to Denver Health that you all created? Or is the mapping standardized in any way it's used in other settings?
The mapping was actually put forward by the Institute of Medicine. It was dependent on 3 things. It was the 2000 census, the Kaiser Permanente mapping, the CDC superset, as well as the Massachusetts superset. So these all came from other sources. This was not our mapping. These have already been published in the literature and have been validated.
Awesome, that's helpful. Did you guys tweak it at all? You just used a combination of different sources, or did you tweak it, or what you use is exactly what's standardized?
Yeah, so and I'm probably happy to share that document. It's the Institute of Medicine document, Appendix E, Table F. It has the entire mapping on there.
Sounds like you've referenced it once or twice. One of my questions when you were talking about training the front desk staff is, it sounds like it was very important, the order in which the front desk staff asked those questions because of the way that you were mapping it. Is that true? It's very scripted.
Correct.
Great. Perfect. I'll open the floor for other questions.
I think Sarah had a question because she had her
Mhm.
hand up.
Last year, we did some quality improvement around the race, ethnicity, language data collection that we're using for this program, for our perinatal substance use programming, because the original data collection protocol for us was asking race and ethnicity as one combined question, rather than sort of separating it by race and ethnicity. The reason that we changed how we're collecting it is to align with vital statistics or birth certificate information, so that we could benchmark better from existing data. And I'm wondering, the vital statistics and birth certificates data collection sort of protocol is from the OMB, right? Like it came from, which I'll put in the chat here what we're talking about when we say OMB. Is there any advocacy work that you know of going on around improving the OMB's race and ethnicity data like categories? Certainly you are collapsing back down into something that's standardized, but what is standardized isn't sufficient.
It is, and I think OMB recognized that. So they put together a public commenting period last year in terms of revamping the OMB categories, and they have decided that they're going to be changing those coming soon. I think the ballpark is somewhere around June or July of this year. Ethnicity, as we all know, because race and ethnicity is such a weird concept, because people are like, what do you mean by ethnicity? My ethnicity is my race. How we asked ethnicity was not what is your ethnicity. We asked if you're Hispanic or Latino, right? Because that is the only ethnicity that we ask in the US. That is gone. The race categories are going to be now what we already have. They're going to add Northern African, Middle Eastern. They're going to add South Asian, and they're also going to add Hispanic or Latino as their own races. So it's only just going to be race categories. The OMB is also suggesting that within those race categories, you collect certain ethnic backgrounds, which is really interesting. So if you are from, if you identify as Hispanic or Latino, the questions you would be asked, you can ask in addition to that, are you Mexican? Are you Mexican American? Are you Chicano? Are you Venezuelan, Honduran, countries of interest that we've seen a lot of immigrants that have come here to the United States from. So they are encouraging that, but they will require you to collect the granular races. They will not require you to collect the subcategories of those races, which define your race at that point. So yes, the OMB is simplifying it a lot more with just one category, race. And within those categories of race, they've recognized that there are certain races that never ever fall into those categories. So for example, Afghani or Afghanistan, Afghanis do not recognize themselves as white, but we categorize them right now as white. They, in our own community, they've been choosing a lot of the times they're saying other. We don't. So now they're going to be part of South Asia or Middle Asia, or they might recognize themselves as South Asian, which certainly tends to be what it is, or Middle Eastern, right? They have those two options. So it's going to change here coming soon. We are primed because we started collecting the subcategories, right? So we started collecting your ethnic background. So for us, it'll just take a flip of the switch and just remap all the individuals from those countries to the new categories. For other organizations, it's going to be a little tricky because you have probably mapped those individuals as race white. So let's say if you have an Afghani woman who is coming back to your system, how do you change that data from white to Middle Eastern or South Asian? That is going to be the tricky part. OMB has not given any kind of toolkit or strategy on how to address those new categories once they come out.
It's going to be like the year 2000 all over again. Nobody's going to know what's going to happen.
Pretty much.
I hate to wrap this up because we have a ton of great information that could come. I'll give like 2 more minutes for open questions if you guys have anything you want to add. While you're thinking, I'll add this question. You mentioned SOGI data, which is sexual orientation and gender identity data. Are you guys doing any improvement processes around how that data is either collected or used?
So our SOGI data collection practices vary by site. Our ACS, which is our ambulatory care centers, have done a remarkable job because now it's considered standard work. So we have a preamble to ask that question from a 24-year-old trans woman to a 79-year-old grandmother from Venezuela. We ask exactly the same way. We explain to them what gender identity and sexual orientation is, to which we get some really colorful, fun responses from some of our patients. But how we structured it is it's part of our rooming. We ask in the order, the pronouns is the first thing, and we explain to them what a pronoun is, how we would like you to address them, and then followed over by gender identity and then sexual orientation, primarily because gender identity and pronouns tend to be more universal in some ways. The sexual orientation we do ask, but people generally say I do not want to answer in certain in certain diasporas, versus majority of them I'm like, I'm straight. Our collection rate is at 96% in our ambulatory centers. It's 70% system-wide. One of the places we haven't done a great job with is collecting that information from our individuals who are coming to the emergency room or inpatients, especially in our homeless population. So there is a new, which is funny you brought that up, because that is my new project that I'm working on right now, is revamping the preamble on how to collect this data, making it more patient-friendly, having the language that is universal and patient-facing, as well as descriptions and training for when patients respond to, what are you going to do with this data? What do you mean what my pronoun is?
It sounds like it's a good excuse for us to have you back in a bit to give us an update on how that's going. Kylie left you a question in the chat. I'll leave you to answer that. Guys, please use the chat in these last few minutes while Corey is still with us. Corey, thank you. We appreciate your time. The work that you're doing is really exciting, and we're hoping that it can be replicated in other spaces. Sarah, I'll turn it back to you.
Which member of the staff was asking verbally as a confirmation? It was the registration staff that from Katie asked me that question. Yep, the order was important. Denver Health at the team. If you're asking the health related social needs and L&D, I can email as well. Kylie, I don't know about that one. The health related social needs and L&D admission. I do know that this became, it was generally from patient navigators that were asking this question in pediatrics as well as in ACS. Those were the two sites that were chosen to ask the health related social needs questions, but I can, I'll email the person who's heading that project and send you a response.
That would be great.
Mm-hmm.
Thank you.
Actually, I think this is me, Sarah. Thanks. We wanted to give an announcement that these are monthly standing meetings. Please add them to your calendar. We have some really, in addition to Corey, we have more exciting speakers coming up in the coming months. In February, we're going to have a speaker come and talk a little bit about toxicology, actually. I think I got the order wrong here. Toxicology is next month, about how are you implementing your toxicology guidelines? What are the barriers that you're seeing for revising current guidelines? And then we're also going to have a hospital team come and give some updates on how implementation of perinatal substance use programming is going at their site. And so we're going to get not only a case study about patient care and how that transpired at their site, but we're going to get an update on how they're doing with policy changes and how it is that they're working with their pediatric colleagues, and an opportunity to ask them questions about implementation. And so I think there's so much benefit in shared learning. That's why we're here. And so I think next month is going to be particularly interesting. And then, my apologies, I switched that. In March, we're going to talk about plans of safe care. We're going to bring in our pediatric colleagues from the Chosen Collaborative, which is the Substance Exposed Newborn Quality Improvement Program. They're going to be with us on that call. We know that plans of safe care is a partnership between maternal and infant and social work. And so we want all those perspectives present for you guys to sort of learn what's the process, how can we make it better, how can we make it really a collaborative. If you guys have suggestions for topics that you want to hear about this year, if you have speakers that you've heard recently that you're thinking, I would love to hear them again, or our audience really would benefit from hearing, please let us know.
Okay, and we just wanted to remind you of the training that we are offering as part of CPCQC COIM SUD. We discussed these findings last year at one of our later webinars, but members of our team sent out a survey to hospitals around the state of Colorado to gather information on any stigma and bias that they're seeing in their units. And we got some really great feedback. A member of our team, Carly, then put together a training with Hard Beauty. And so we had some really great feedback from that as well. So we are going to be offering this training again. If you and your units are interested, please scan this QR code. We will also be sending a link in a follow-up email, but just wanted to promote that here as well as we go into this new year. And then also a reminder of the dates of our expert training for this next year. We will have 2 sessions on April 17th and then 2 sessions October 16th. They will be in person and virtual, and we encourage all of your staff to attend. Even if they did expert training a couple of years ago, it'd be great to have a refresher. It's free to all of you. And CEs will be available, and we will shortly be sending out the registration link as it is available. And then I'll pass it back to Amber.
I'll do one last plug. Our sister quality improvement program is for our cesarean reduction work. We are revamping that program in the coming year for a time-limited, like a 1-year learning collaborative. We've already enrolled 20 birthing hospitals in the state to participate in that. Enrollment for that quality improvement program ends on the 15th. You have 4 more days. We're really excited about it. We talked about collaborative learning just a minute ago. The focus of this program is truly collaborative learning. Having hospitals come before each other, share what they're doing, learn from what other hospitals are doing, sharing struggles, challenges, wins, sharing resources that have been developed for cesarean reduction efforts. So if your hospital's not already enrolled, reach out to us. We'd love to give you more information. If you don't know if your hospital's enrolled, reach out to us. We will tell you if they are. We also have an in-person forum in February that's associated with our cesarean reduction efforts. We have some amazing speakers lined up for that forum. And so if you want some more information on that, reach out and let us know.
And we will open the floor again for a few more minutes to ask any lingering questions that you may have of either the CPCQC team or Corey. You can either put those into the chat or come off mute, but we really appreciate you attending today. That was a great presentation. We hope that you were able to take some snippets back to your team that you can incorporate into your data collection and race, ethnicity, and language. So thank you all very much. Feel free to ask any questions.